Welcome to the SoTM module on energy. Prior to this, you would have received pre-course learning materials, and it is essential that you would have gone through this. This session will summarize the key points from the learning materials. I will cover the principles of tissue management and the energy-based technologies used in surgery. At the end of the session, you may bring up any questions that you might have. The goal of tissue management in surgery is to optimize patient outcomes. It must be recognized that the utilization of any surgical device requires interaction between the user, the device, and the tissue. Each of these has characteristics that can affect the outcome. Understanding these characteristics is crucial to maximizing the effectiveness of the device. Human factors include the experience, skill, and fitness of the user. Tissue factors refers to the composition and biomechanics of living tissue, while energy-based technology, which is constantly evolving, must balance compression, time, and heat in optimal device-tissue interactions. An example of tissue management is the construction of bowel anastomosis. As far back as the early 1900s, Dr. William Stewart Halsted established the principles for performing a safe anastomosis, which hold true till today. These are meticulous hemostasis, maintenance of good tissue vascularity, and minimization of injury, bacterial contamination, and tissue tension. While energy devices do not have a direct impact on bacterial load or tissue tension, they can impact hemostasis, tissue trauma, and potentially blood supply. Energy can be defined as the capacity to do work, and energy-based devices are such an integral part of surgery now that you might not have stopped to think why we do not get electrocuted or how best to use the different types of energy. By the end of this talk, you should be able to answer the questions listed here. Energy devices are used to effect cutting or coagulation, or a combination of the two. The ideal energy device should be versatile, multifunctional, safe to both patient and surgeon, easy to use, cut and coagulate effectively with minimal tissue injury or charring. This poses a huge challenge to design developers, as optimizing cutting negatively impacts coagulation, which is an important component of hemostasis, and vice versa. To understand this further, let's look at the mechanism of hemostasis. Hemostasis is achieved through three processes: vasoconstriction, which is the shrinkage of vessels; platelet aggregation, which is the formation of a hemostatic plug; and coagulation, in which fibrinogen is transformed into polymerized fibrin, i.e. a clot. This process could take several minutes. The clot attracts and stimulates the growth of fibroblasts and smooth muscle cells within the vessel wall and begins the repair process that ultimately results in the dissolution of the clot through fibrinolysis. We can facilitate hemostasis by using pressure or ligatures, topical hemostatic agents, or energy devices which compress tissues and apply heat over a period of time to expedite hemostasis. How does compression assist in hemostasis? Firstly, it decreases water content and tissue volume. This promotes the fusion of vessel walls, and it also decreases the time for tissue effect, as the increased resistance of compressed tissues means heat is generated faster. Studies have shown that compression is directly related to seal quality and hemostasis. What about heat and time? From this graph, you will see that tissue responds to heat in a very reproducible manner. Irreversible tissue damage occurs at 40 degrees Celsius. Collagen then begins to denature at 80 degrees Celsius and transitions into a desiccation phase beyond 100 degrees Celsius. Temperatures above 150 degrees Celsius result in carbonation and char buildup within the tissues. Additionally, it's important to note that the rate at which tissue temperature rises increases dramatically as water content decreases. Tissues with less water content have shorter sealing times. Therefore, controlling temperature is critical to managing tissue effect and can be impacted by relative water content. Now that you understand the mechanism of hemostasis, let's look at how it can be affected by tissue dynamics. Understanding how different types of tissues respond to energy is as important as understanding the energy itself. We'll explore 3 types of tissues that you might encounter in surgery: blood vessels, fat, and lymphatics. Blood vessels have solid and liquid components, and has been mentioned before, compression facilitates hemostasis by approximating the intimal layers and reducing the water content. However, a very real but sometimes unrecognized phenomenon is the impact of the angle at which the vessels are sealed. A vessel which has a 5 millimeter diameter, when approached perpendicularly, i.e. at 90 degrees, can have its diameter increase by 28% if the angle of approach is at 45 degrees instead. Optimal sealing by energy devices is achieved with a perpendicular approach. What about fat? Since fat has up to 75% less water than muscle, it tends to be less conductive. So in clinical practice, you might notice that when you are operating with a monopolar energy device, such as a Bovie diathermy, the tissue effect is less on fatty tissues. In addition, when using ultrasonic energy, fat tends to liquefy as the energy is applied. Lymphatics are similar to veins in their physical properties, in that they have a low collagen content and are a low pressure system. However, they are milky in color and can at times be difficult to identify. Additionally, depending upon location, the size of lymphatics can change dramatically. The low collagen content means it can be difficult to effect hemostasis using energy devices. The understanding of hemostasis and tissue dynamics has been critical in the evolution of surgical energy devices. This evolution was driven by the need to improve surgical outcomes. As far back as the 1920s, Bovie developed the first monopolar generator that we know now as the diathermy. In the 1940s, Dr. James Greenwood performed the first 2-point coagulation with further refinements in bipolar energy, such as the Cleppinger forceps, throughout the 50s and 60s. By the 1970s to 1980s, generators were further refined with return electrode monitoring. In the 1990s, Doctors Davidson and Amaral introduced the first ultrasonic coagulative cutter, followed by refinements in tissue sensing, current modulation, and adaptive computer controls. By the early 2000s, polymer technology, which controls temperature at the tissue device interface, and advanced algorithms to improve energy output were introduced. Let's now delve a little more deeply into technologies in current surgical use. Electrosurgery is the most commonly used modality, but it's important to understand what this term actually means. Most surgeons use the terms cautery, electrocautery, and electrosurgery interchangeably, but they are actually very different processes. Cautery is the surgical use of heat to destroy tissues. Electrocautery is the use of electricity to heat metal, which is then applied to tissues. No current flows through the patient. Electrosurgery is the use of an alternating current to cut and coagulate tissues, and the current flows through the patient's tissues. A basic knowledge of the physics of electricity is therefore essential to understanding electrosurgery. Current is the amount of electrons flowing, similar to how much water is flowing through a water hose. Current is measured in amperes. Voltage, measured in volts, is the force pushing the current through the circuit. while power, measured in watts, is a function of voltage and current. Electrical current passing through a resistor converts electrical energy into heat energy. So why don't patients get electrocuted when we perform electrosurgery? After all, the current from an electrical outlet, 120 volts traveling at 60 hertz, is more than enough to cause neuromuscular stimulation. The reason is that nerve and muscle stimulation ceases at 100,000 cycles per second, or 100 kilohertz. Today's electrosurgical generators operate at frequencies of 200 kilohertz or above. Since there is no risk of neuromuscular stimulation at frequencies above 100 kilohertz, patients undergoing electrosurgery will not be electrocuted. We'll now move into the specific modalities, starting with monopolar electrosurgery. In electrosurgery, a complete circuit is necessary for current to flow. In monopolar electrosurgery, the current flows from the pencil through the patient to the pad and back to the generator. The patient's tissue completes the circuit. The pencil is small and delivers high current concentrations, while the pad is larger and dissipates the current over the larger area. The tissue effect therefore occurs at the pencil, where current concentrations are high. Waveform refers to the shape of the electrical signal as it travels along the circuit. Different waveforms indicate that the generator is delivering current at different voltages. Low voltage is safer simply because it delivers less force. While any modality can be used to desiccate tissue, the difference is how the current is applied to the tissue. In electrosurgery, there are three basic waveforms: cut, in which current is constantly flowing at a lower voltage; coagulation, in which current flows intermittently but at high voltage; and blend, which is in between. The risk of arcing is greater with coagulation compared to cut due to this higher voltage. Surgeons use electrosurgery primarily to cut and coagulate tissues. Cutting is achieved by an electrosurgical instrument that is in close proximity to the tissues. The instrument doesn't actually mechanically cut the tissue, but uses heat to vaporize it. There are two types of coagulation current: fulguration, in which the tip is not touching the tissue. This is also called non-contact coagulation or spray mode; and desiccation, where the tip of the instrument is touching the tissue, also called contact coagulation. Electrical current follows the path of least resistance. In the human body, resistance to the flow of electricity is directly proportional to the water content of the tissues. The higher the water content, the lower the resistance. As heat dries the tissues, resistance increases and the current seeks an easier pathway. This path is neither consistent nor predictable and can lead to unintended tissue injury. I mentioned current concentration in relation to the diathermy pencil and pad in the monopolar circuit earlier, in which tissue damage is proportional not only to the power applied, but also inversely proportional to the area of contact. Think of a magnifying glass as it focuses the sun's rays to a small object. This will cause an increased heating effect to the smaller targeted area. This is similar to what happens when eschar builds up on the tip of an electrosurgical pencil. Impedance increases and can cause arcing or sparking, which can potentially cause unexpected tissue effects to occur. Let's look at how these principles manifest themselves in surgery. In this example, the surgeon is mobilizing the gallbladder from the duodenum with a monopolar hook. But something very interesting happens as the tissue desiccates and resistance or impedance increases. When the surgeon applies the energy initially, the tissue effect is localized on the gallbladder side of the adhesion. When the surgeon reactivates energy where the tissue has been desiccated already, the current begins to seek the path of least resistance. This is on the duodenal side, potentially resulting in duodenal injury. The other factor that compounds this issue is the fact that the surface area of the adhesion band on the duodenal side is smaller and results in increased current density. The fact that the injury occurred is only part of the problem. Since this is an alternate site injury, the surgeon is typically not looking for this. Oftentimes, it only manifests itself post-operatively. While this is a lap chole, this situation may also occur in adhesiolysis or any procedure where mobilization is required. While technological advancements have greatly reduced the risks of electrosurgery, the potential for complications is still present. Return pad failure occurs if the return electrode is not in full contact with the patient's skin, and a burn may occur at the site of the return electrode. In alternate site burns, a ground reference system, which then has a metal object making accidental contact with the patient, may cause the electrical current to exit the body. This would result in a burn at the exit site. Direct coupling occurs when an active electrode is activated too close to another conductive instrument or metal object, while capacitive coupling occurs when two conductors are separated by an insulator. Both can cause unintended injury. Insulation failure occurs when the coating that insulates an active electrode is compromised, also potentially causing significant injury. Surgical fires are one of the most serious risks in surgery. The operating theater environment with the presence of fuel, heat, and oxygen is ripe for such an incident, should heat from monopolar electrosurgery create a spark to ignite the fire. Direct coupling may be intentional. For example, when a surgeon touches an active electrosurgical instrument to the forceps to coagulate a small vessel. However, sometimes instruments come into contact with one another unintentionally, usually outside of the field of vision. This is common in laparoscopy. This may also be a concern when operating through a single incision. Instruments can cross one another in tight spaces and can transfer energy from an active instrument to an inactive one. As mentioned, capacitance is stored electrical charge, and a capacitor is a device that stores this electrical charge. When two conductors are separated by an insulator, a capacitor is created. As a result, a current in one conductor can induce a current in the second conductor. The capacitively coupled current wants to complete the circuit by finding a pathway to the patient's return electrode. The charge is then stored in the capacitor until either the generator is deactivated or a pathway to complete the circuit is achieved. Potential sources for capacitive coupling include a metal trocar cannula around an active electrosurgical instrument, an active electrosurgical cable wrapped around a metal towel clamp, and a metal total hip prosthesis. Compromised insulation can create an alternate route through which the current can flow. If the current is concentrated, it can cause significant injury. It is counterintuitive but true that a small defect would concentrate the energy at a higher level, causing a greater injury than a large defect. Causes of insulation failure include use of high voltage coagulation waveform, repeated trauma during insertion through the valve, repeated electrical heating, and repeated sterilization, as well as manufacturing defects. Understanding the basic principles of electrosurgery can help you to reduce the risks of patient injury. Safe use of electrosurgery includes use of the cutting current whenever possible, as it uses lowest voltages, therefore minimizing arcing and sparking, and therefore unintended injury. Use of the isolated generator and return electrode monitoring prevents ground pad and alternate site injuries. Use of the lowest power setting is possible. The use of the lowest power setting should be used. Check the insulation on all instruments before use, and avoid an open circuit by not activating an electrode of tissue, and always cleaning the eschar of electrodes. This graphical representation shows directionally what is going on with regards to heat, compression, and time. As you can see, monopolar energy is characterized by low compression, high heat, and relatively short time on tissue. This graphic will be useful for you to compare its performance with other modalities later. We move on to traditional bipolar electrosurgery. In bipolar surgery, no additional indifferent electrode or return pad is needed, as the tines of the forceps act as two electrodes. Electric current travels only between the two electrodes and through the tissue grasped by the tips of the forceps. The targeted tissue therefore completes the circuit. Bipolar electrosurgery minimizes sparks as tissues are in direct contact with both electrodes. However, as the tissue desiccates, the resistance increases close to the electrodes. This causes the current to balloon around the electrodes. As a result, damage extends beyond the point of contact. Damage may extend even further as heat percolates to the adjacent tissues. Traditional bipolar devices are not used to effect cutting. They can be used to effect hemostasis, which, if you recall, is achieved through heat, time, and compression. Traditional bipolar devices maximize the use of heat and moderate compression to denature proteins and coagulate vessels, but as you can see from the diagram, might not effect true sealing of the vessels. To summarize, in comparison to monopolar energy, traditional bipolar energy is characterized by increased compression, high heat, and increased application time. Recognition of the limitations of the traditional bipolar modality led to the development of advanced bipolar electrosurgery. The advanced bipolar circuit is similar to the traditional circuit. However, improvements in device performance have been developed, including lower voltage systems and better sealing through better compression, heat, and time management. Advanced bipolar systems have improved compression by switching from the conventional spring and pin mechanism, where a spring in the handle delivers force around a pin fulcrum, to a controlled gap. This is similar to endocutters, where the bottom and top jaws are pulled together to an evenly spaced specific gap, unlike spring and pin, where the gap close to the spring may be different from the gap further away. This is illustrated in this graph. The controlled gap mechanism leads to increased compression throughout the entire length of the device, thus increasing the effectiveness of vessel seals. Another potential benefit is the removal of more water content, resulting in less steam formation. As previously explained, traditional bipolar instruments utilize one active and one return electrode, with the potential for ballooning and unintended injury as tissues desiccate. Advanced devices utilize the offset electrode configuration, where two active electrodes are surrounded by multiple return electrodes. This focuses current flow within the jaws, minimizing stray energy and lateral thermal spread. Advanced bipolar generators are also better able to control heat by measuring changes in impedance and adjusting the voltage and current accordingly. Another way to control heat is through positive temperature coefficient technology within the device. Thermoelastic, heat-sensitive polymers are conductive particles embedded within both jaws. These conductive particles are normally organized in a fashion which allows for current delivery, as you can see in the picture on the left. When the polymer reaches 100 degrees Celsius, the conductive particles disorganize and current ceases, which you see in the picture in the middle. This allows customized delivery of current based upon localized temperatures, which you can see in the picture on the right. The combination of better compression, heat, and time management means that advanced bipolar systems are able to effect better vessel sealing in comparison with traditional systems, as seen in these histological specimens. The advantages of advanced compared to traditional bipolar are summarized in this graphic, which shows significantly increased compression, less heat generation, with no increase in time required. Finally, we move on to ultrasonic surgery. The energy flow of an ultrasonic device differs significantly from monopolar and bipolar systems. Electrical current is delivered from the generator to a transducer or handpiece. And within the transducer, electrical current is converted to a mechanical wave. No electrical current is passed through the patient. In ultrasonic surgery, both cutting and coagulating rely on the mechanical propagation of sound waves from an energy source through a medium to an active blade. There are three spectrums of mechanical waves. Infrasonic waves have frequencies below 20 cycles per second. Audible or sonic sound waves are confined to a frequency range of 20 cycles per second to about 20,000 cycles per second. Ultrasonic mechanical waves have frequencies above the audible range, which is 20,000 cycles per second or greater. Ultrasonic instruments used in surgery operate at 55,500 cycles per second or around 20 kilohertz. In the Ethicon harmonic system, the handpiece houses the ultrasonic transducer, a stack of piezoelectric ceramic discs sandwiched under high pressure. Applying electromagnetic energy to the piezoelectric ceramic discs produces an ultrasonic mechanical wave, which is passed down the shaft of the instrument. Once the wave reaches the blade extender, it causes the blade to expand and contract longitudinally at 20 kilohertz. When the blade is coupled with a tissue, it creates intercellular friction within the tissues, breaking down hydrogen bonds and resulting in protein denaturization and the formation of a sticky coagulum. Therefore, an ultrasonic instrument eliminates the risks of electrical injury to the patient and surgeon, since there is no current flowing through the patient. This animation illustrates what happens within the titanium blade in an ultrasonic device. In ultrasonic surgery, factors associated with increased cutting decrease coagulation, and those associated with increased coagulation decrease cutting. There are 5 specific factors a surgeon controls when applying ultrasonic energy: blade pressure, tissue tension, blade sharpness, power level, and time on tissue. Increases in blade pressure, tissue tension, power level, and blade sharpness, as well as location of the tissue towards the tip of the instrument, are associated with better cutting. A reduction in any of these factors will increase coagulation. All of these factors are further influenced by the duration of time of application, tissue type, and the thickness of tissue being cut or coagulated. Both ultrasonic and electrosurgical devices denature protein by the transfer of energy to the tissues. Ultrasonic devices use mechanical vibrations, while electrosurgical devices use high-frequency alternating current. Ultrasonic energy generates a secondary heat from internal tissue friction as a result of the high-frequency vibration of tissue. The titanium blade used to transmit the energy allows it to retain heat. This combination of heat and compression allows ultrasonic instruments to simultaneously cut and coagulate vessels up to 5 millimeters in diameter with specific shears and up to 2 millimeters in diameter with blades. Vessel sealing is achieved at temperatures with ultrasonic energy that are lower than with electrosurgery. Electrosurgery can generate increased tissue temperatures in excess of 400 degrees Celsius, resulting in desiccation, char, and lateral thermal spread. Ultrasonic instruments enable a surgeon to cut and coagulate tissues simultaneously. Cutting with an ultrasonic instrument is entirely different from cutting with an electrosurgical instrument. With electrosurgery, cutting is achieved using a current. The current creates higher tissue temperatures in a shorter period of time, leading to rapid expansion of intracellular fluids and cell explosion or vaporization. With an ultrasonic instrument, cutting is achieved with direct contact of the blade to the tissues, comparable to cutting with a conventional cold steel scalpel. In coagulation, heat and pressure are required. A shear provides compression to the tissues through the engagement of a clamp. Tissue is placed between the blade and clamp arm. Ultrasonic instruments are multifunctional, so in addition to cutting and coagulating, they are also able to grasp, backscore, drill to create otomies, and provide cavitation to help define tissue planes. The motion of an ultrasonic blade creates an area of transient low pressure, causing intracellular fluids to vaporize at lower temperatures. The fluid vapors expand, causing the tissue layers to separate, which enhances visualization and dissection. This is what is known as cavitation. The ultrasonic shears and blades, therefore, have distinct characteristics. The blades provide less compression, similar to monopolar instruments, but generate lower heat and require more application time, depending on the technique used. The shears generate increased compression from the clamp arm, effecting hemostasis with relatively low heating of the tissues in a short amount of time. In comparing energy devices, we also want to compare the extent of tissue injury generated. Two aspects are important: depth of injury and lateral injury. This slide shows that the depth of injury in ultrasonic devices occurs more gradually than in monopolar devices, but with time will reach the same level. Thus, time management is important. However, with respect to lateral injury, although injury from ultrasonic devices did increase with time, it was always less than that inflicted by monopolar devices. In summary, energy devices affect cutting and coagulation of tissues variably according to the degree of compression, heat, and time applied, and the properties of the tissues themselves. An understanding of how devices work is critical to exploiting their advantages while avoiding adverse effects. Thank you.